Good morning, everyone. Thank you very much, Zoltán, for the invitation. I find it very challenging to be the very first presenter of a very first occasion, probably of
It's history, András. It's
history. Yes. I feel like myself, probably I will be written in a history book. Okay, so just kidding. So I find it a challenge to present the very first lecture today. And usually the organizers are expecting discussing specific topics. However, today I would like to also give an overview about lung monitoring. So what are we going to speak about? Without the knowledge of history, it's not just interesting, but we can't raise questions about the future and not even today. Somehow we are going to meet a nice loaf of Hungarian white bread. I would like to escape averaging about lung monitoring. We are going to speak a little bit about the pathophysiology of acute adult respiratory distress syndrome. We are going to touch upon a little bit of optimal monitoring of lung physiology, and with the help of electrical impedance tomography, I'm going to show you how we can improve lung monitoring in an everyday practice. So how would you start the monitoring of your respiratory system? With listening, and all of the medical devices, the stethoscope is a very simple, easy to use bedside equipment. All of the medical devices have advantages and disadvantages. And the stethoscope was invented by Linnæus in the 18th century because he found very indelicate to listen to the chest of young ladies directly with his ears. So he just simply rolled a piece of paper and he improved the distance between the skin of the young lady and his ears, and here is one of the very first stethoscopes of Linnæus. The next step was, because there was always a huge demand to look into the body, the invention of the X-ray, what was one of the greatest inventions in medical history. The problem is that it gives you a summation of picture. So the next step, what really revolutionized visualization, was the computerized tomography on the field of radiology. And now, in the last, let's say, 15 or 20 years, we are in the era of ultrasound using on an everyday practice on the intensive care unit. And of course, we should also mention the ventilator by the bedside, because loads of data runs on the screen. However, again, it has advantages and disadvantages. The data on the screen is the renal response of different tidal volumes pressured into the respiratory system of the patient. However, we should emphasize that this data, what's running, it's just an approximation of the respiratory system and does not give you any detailed information about specific lung regions. So how do you interpret your measurement? Here is the nice loaf of white Hungarian bread. When you are slicing it, you are expecting homogeneous, very similar bread within the crust. But it does not hold even true for a healthy lung. If you think about the West zones, there is a very distinct and different lung regions if we look into the pressures of the vessels or even the alveoli, and not mentioning a COVID-infected lung, what is really inhomogeneous from this perspective, from this point of view. So we should escape averaging, because what we are reading on the ventilator or what we are measuring as an end-tidal carbon dioxide or partial pressure of arterial oxygenation, it's produced by very different lung regions, not mentioning that probably these results are coming from properly measured, ventilated, perfused lung regions mixing with shunts. As I mentioned to you, without basic knowledge of pathophysiology, we can't carry on about the discussion. And the acute lung injury is a very good example of the inhomogeneous injury of the lung. We all know that Ali has extrapulmonary and intrapulmonary trigger factors. The common in all of them, that all leads to an inflammatory cascade. It begins with the cytokine storms induced by the innate immune cells, activating neutrophils, and they start to release damaging agents. The endothel and the epithelial is disrupted. Thank you. And this leads to an extravasation of the intravascular fluid into the alveoli through a development of intraalveolar edema, and the surfactant is washed out. The problem is that if the surfactant is washed out, the wall tension is reduced, the alveoli collapse, the ventilation is reduced on that lesion, and this leads to a formation of further shunt fractions. And this chain of events ultimately leads to an inhomogeneous damage in the lung. So how would you monitor this inhomogeneous injury? Here is, I've written just some words about how I expect or how I imagine an optimal monitoring technique. However, we should mention, and we all know that it does not exist at the moment. So to solve this problem, we established an international consortium with members of European universities, private companies, physicians under the lead of the Technical University of Budapest. And as I mentioned to you, I would like to show you how we can improve this lung monitoring of inhomogeneous injury through a clinical study. The electrical impedance tomography is a good clinical example for monitoring in action. EIT involved the application of low frequency, low amplitude alternating electrical currents through 16 electrodes around the chest. These electric potentials are then reconstructed in a tomographic manner, and the basic principle behind the EIT that different tissue have different impedance quality, what we call bioimpedance. These belts of the EIT is attached around the chest, as I mentioned, and can measure either absolute changes in impedance or relative impedance changes. The data obtained from these measurements can be analyzed either as waveforms or real-time pictures. And one of the major advantages of this system is that the picture can be divided into segments or focused on a specific region of interest. A couple of years ago, Gattinoni described two different clinical phenotypes of COVID-19 lungs. The L type is characterized by low elastance, high compliance, low ventilation, perfusion, low recruitability. In contrast, the H type, the high type with high elastance, high right-left shunt, and high recruitability. The identification of subpopulations must differentiate response to treatment, ideally by defining subgroups with distinct functional or pathobiological mechanisms, what we call endotypes. Here we are speaking about probably not two phenotypes, but two endotypes, the L type and H type, requiring very different approach of treatment during mechanical ventilation. So our basic idea was, if we can also differentiate these two types by electric impedance tomography, or even if we can give further details about this inhomogeneous injury. So we constructed an investigation. We included patients orotracheally intubated, ventilated in pressure-controlled mode, and the major exclusion criteria was end-stage COPD, severe hemodynamic instability, and severe bullous emphysema, because all of these patients underwent a PEEP incremental and decremental trial. Now I would like to emphasize that please don't look at a proper clinical trial, because we could also involve only two patients, so it's rather a case series, because the influx to our COVID ICU was very low during the first wave of COVID, thanks to the successful closure in the very beginning of 2020. So we could involve 2 patients. Here are the patient characteristics, and please pay attention to the levels of oxygenation and the time elapsed since the development of the first symptoms before admission. And of course, all of you are very familiar about the CT scan of a COVID-infected patient. So first, I'm going to present the research guideline. As I mentioned, all of these patients were ventilated in a pressure-controlled mode with 15 water centimeter of pressure. We started on a PEEP level of 10, and in a stepwise manner, we increased the PEEP to the top level of 25 in every 2 seconds, and after we went back to the basal PEEP of 10. And on each step, we performed an end inspiratory occlusion and inspiratory hold maneuver to measure the plateau pressure, the static compliance, and we also measured and observed the vital parameters. We took blood gases at the very beginning and very end, and of course, through the whole PEEP trial, we measured and recorded the electrical impedance tomography. Here is the cumulative compliance. Both of the patients before and after the PEEP trial showed that patient A had significantly higher compliance than patient B. And this suggests that patient A can be identified as a low type, low elastance, higher compliance, and patient B as an H type, the high elastance and low compliance. I would like to mention that compliance improved significantly in both of the patients. And if we assess the compliance over time, we can observe a significant decrease in static compliance for patient A as days progressing, but not for patient B, showing us that patient A was admitted in an earlier phase, and probably this lung became stiffer just later on, probably due to the activation of fibrosis related to the inflammatory process. And when we are using EIT, it is possible to assess regional lung mechanics by utilizing pixel compliance for estimation. The tidal volume is closely associated with the pixel-wise conductivity variation, as shown in the EIT tidal image. And pixel compliance means nothing else, that it's the conductivity difference over the driving pressure. So with the help of this pixel compliance, we could estimate the over-distension ratio at the highest PEEP level and the collapse ratio of the lung region in the lowest PEEP level. And we could also measure the optimal PEEP level, what can be determined by the EIT. The crossover point between the curves of the decreasing line of over-distension and the increasing line of collapse indicated the optimal PEEP, where the level of the 2 opposing factors was meeting. And for patient A, as you can recognize, we measured lower and lower optimal PEEP level day by day. And for patient B, who was the H type, it was just fluctuating. We could also estimate the rate of cumulative collapse and distension. For patient B, who was the H type, he was significantly less likely to experience collapse following the PEEP trial. And we then analyzed the change in collapse ratio over time. We observe a significant decrease in patient A and not for patient B. The cumulative collapse ratio was a useful tool to differentiate L-type, patient A, from H-type, the patient B. And furthermore, the alteration in collapse ratio by time was capable to pursue the transition from L-type to H-type with patient A, just Dattinoni described in his article. So if I call myself as a photographer, I could take a snapshot about this transition from L to H type. So the conclusion is that unlike Gattinoni suggested in his article, with the help of EIT, we estimated higher optimal PEEP level for the low type. And from statistical point of view, we found significant recruitability also for the low type, not like Gattinoni described. And altogether, I would say that COVID-19 infection in the lung is rather a spectrum disease, where the low type can transit into H type, what we could also reveal with the help of the EIT. And I would like to emphasize that beyond patient-tailored therapy, now we should tailor our therapy on a time manner, because as you can see, these lungs were fluctuating day by day. So now we are in the era of highly precise medicine, what I named yesterday as Hype Me. Who knows what's going next about Hype Me. Thank you very much.